Good morning, and welcome to today's Seinfeld discussion on the jacket. For our clerks today, where would you like to start? Any particular character, any particular scene that you'd like to discuss? We could also include our interns. Any place you'd like to begin our discussion this morning on Seinfeld's The Jacket? We could even start with a character.
Maybe Elaine's dad. I think he's a very interesting character to discuss.
With regard to Mr. Bennis, this is Elaine's dad. What from a behavioral perspective did you find interesting? And anything different that you think would or might be the focus of clinical attention?
I think the fact that he doesn't seem to understand how uncomfortable he's making other people, and that the conversation was very difficult between him and Jerry. And yeah, I just thought it was interesting how he didn't seem to pick up on any social cues.
Very true. And I have a question for the group. If what he discusses changed, do you think that people, and changed for the better in terms of perhaps the topic he was discussing, et cetera, do you think people's reaction to him would change significantly, or do you think people would still experience things the same when around him?
I feel like even if the topic changed, it might have been kind of the same result. It's just how, I guess it's the particular, it's like, because in the episode, even when they were trying to talk about something kind of like common between them, he would just make like a particular comment that would just make it awkward in the end. So I would say even if it was for the better, I think it would be kind of like the same result personally.
Now I want to talk about his communication or language in a bit, but I think one of the points that we have to address is that this particular character has significant nonverbal communication. Whether we want to call it body language, we could label it in many different ways. I think the fact here is that Mr. Bennis demonstrates how critical it is to understand that you might be communicating non-verbally and what your messaging may be. And of course, in our case, first and foremost to our patients. Our patients might actually experience this as a form of bedside manner. So you could be at bedside and you could think that you are conveying positive information, discharge planning, negative test results. But if your nonverbal communication is sending a different message, the individual you're caring for can be made to feel quite uncomfortable, and perhaps even as uncomfortable as people like Jerry and George. Okay, even Elaine admits it. Right. So nonverbal communication is critical to the understanding of empathy, as well as general patient-doctor contact. So that's a major teaching message. It's not one that's likely to come up on the shelf exam, but it is absolutely a topic that will certainly impact your medical career. So never forget that. And I think that Elaine's father definitely demonstrates this. In addition to his nonverbal communication, however, Mr. Bennis, when he communicates verbally, AKA language, also, I believe, has some deficits. Now, this allows us to segue to aspects of the mental status exam, speech/language, is part of the routine mental status assessment. And along different parameters of speech, volume, tangentiality, circumstantiality, linearity, etc. Speech is also going to give us insight into one's affect, right? So first, just to review some basics with regard to routine MSc findings. Speech, I think volume is fairly straightforward. Beyond volume, every descriptor that we have for speech is also a descriptor that we may use for thought process. So with the exception of language, speech and thought process are the same thing. And I think that's one clinical point that the clerks definitely have to pull out of this discussion. And that is when you present your MSc findings, present either under speech or under thought process. Do not duplicate your effort because you're really talking about the same thing. You're really reporting on the same thing. And you don't want to begin to use different terms when you describe the same process. What I would strongly recommend is you put this all under the header of speech so that you allow yourself to use volume as well. And when it comes to thought content, thought process, simply omit thought process from your mental status exam presentation. Because again, everything that you are reporting under thought process or about thought process will be reported under speech. That said, normality, that is with regard to one's speech, is linear. They get to point A or from point A to point B in the most direct way possible. That is culturally sanctioned, right? So being linear, being goal-directed, being normal, all of those are interchangeable terms that reflect no deficits in speech/thought process. However, there are a couple of labels, there are a couple of diagnostic terms that we use in presenting or reflecting abnormal findings. One is when an individual veers off topic, but after a certain amount of time, get back to the topic at hand. That is called being circumstantial. On the other hand, if the individual veers off topic and never gets back to the question asked or the topic at hand, that's called tangential. So circumstantiality, tangentiality are abnormal MSc findings for speech. The normal baseline is either called linear or goal-directed speech. So some very quick terms. Before I get to the next point, are there any questions? Another component of the routine mental status exam is affect. And one of the ways in which clinicians arrive at affect is to listen to one's speech, right? So you could present your findings under speech, but now you also have information about one's affect as well. Affect has 5 domains, and I think Elaine's father demonstrates deficits in a couple of these. Anyone have any guesses as to what the 5 domains of affect are? Number 1's the type. So this is the examiner's report about what type of affect or mood the individual is experiencing. This is a time where you keep it simple. Very commonly used terms to describe the type of affect include dysphoric, anxious, expansive. Those and the other one would be irritable. Those are the 4 that you'll hear most commonly reported with regard to one's affect. Next is one's intensity. That is, over the course of your conversation, over the course of the 30 minutes of observing Mr. Bennis, what was his average intensity? How intense was he? There are a couple of terms you need to know here that represent below average intensities. If an individual comes in and is in discussion with you, perhaps during a routine mental status exam, perhaps during a comprehensive psychiatric evaluation, on average, over the course of your discussion, if they get a D grade, if they are below average, you're going to call that blunted. On the other hand, if their intensity is significantly below average, a failure, an F grade, they're going to be called flat. I would think that Mr. Bennis demonstrates a blunted affect in the episode The Jacket. Now, where blunted ends and flat begins is arbitrary, but I think we'd be correct in saying, arbitrarily saying, that Mr. Bennis demonstrates a blunted affect in The Jacket. The third domain is range. And that is, now that we know the average intensity, over the course of the 30 minutes, what are the peaks and the troughs? I mean, there are some situations in which individuals get riled up and may peak or demonstrate a peak in intensity. And of course, over another part of the conversation, an individual may demonstrate a trough. So there should be these peaks and troughs throughout the duration of one's conversation. When the distance between a peak and a trough is minimal, we call that a restricted or constricted range. And of all the different things that I think this character brings to the table for discussion of mental health, I think Mr. Bennis best demonstrates a very and severely constricted or restricted range. I mean, his emotions just are a singular variety, period. You don't see anything either high or low. He maintains a very restricted or constricted range. Now, those two terms, restricted, constricted, are interchangeable. The fourth domain is congruency or appropriateness. That is there a match between what the person is saying and the affect that you are observing, right? Congruency. And again, over the course of a conversation, a psychiatric evaluation would be 60 minutes. We would think that the peaks match the content while the troughs also match the content of what the individual is conveying. And finally, we have change pattern. How quick does one go from a peak to a trough or vice versa? So if you think of point P and point T, connecting those 2 points, the high point of the peak, the low point of the trough, what is the slope of that line? And one term you'll hear quite often that is abnormality is mood lability or a labile affect. That is, the slope of that line is too steep. So those are the 5 domains. I think that we have a character that certainly demonstrates abnormalities, if you will, deficits in affect, including a severely restricted affect. Any other thoughts about Mr. Bennis? Any other characters you'd like to discuss this morning? What's going on with Jerry?
I guess with Jerry, he feels like his jacket defines him and he holds it to this like unhealthy level of admiration.
He really does. You know, and we've talked about this before. Jerry, as well as other characters in this situational comedy, do demonstrate this external locus of control. People's opinions about them are significantly weighed in their own self-evaluation. That, of course, would be different than someone with an internal locus of control, where outside of being a formal like evaluator or supervisor, an individual's opinion of themselves is not duly influenced by others' opinions of them, right? And this group, and there's several episodes that certainly demonstrate this. To each individual, this group does appear to have a significant external locus of control. It is very meaningful. That is, others' opinions of themselves are extremely meaningful. We also see that there was some commitment in getting the jacket. So it was almost as if Jerry's need to have it admired would be a confirmation of the early struggle he had to buy it in the first place, the commitment that he made. Remember that he is a little bit torn with regard to the lining. And I would think even has intrusive thoughts, obsessions about buying the jacket towards the beginning of this episode. And if that were to continue, and if that were to be clinically significant, that is, cause this character clinically significant distress or impairment, the single best answer likely would be obsessive compulsive disorder. And so OCD is a mental disorder in which the individual is experiencing intrusive thoughts, obsessions, or ritualistic behaviors, compulsions that are clinically significant. The definition is fairly straightforward. And even without any compulsions or compulsive behaviors, Jerry still would rule in if his intrusive thoughts or obsessions impacted his functioning. So OCD would be on the table here. How does Jerry resolve the concern with regard to it being swayed and therefore perhaps being damaged?
He gives the jacket away.
Before that. But because it's going to rain, what does Jerry do to the jacket?
He turns it inside out. Oh, sorry.
Yeah. Yep, exactly right. And I thought that was interesting because when we look at obsessive compulsive disorder, and if we were to treat OCD, we understand that there are FDA-approved medications, but what we also understand is that psychotherapy could be of tremendous value. And one of the things that one might look forward to with regard to psychotherapy from the therapist's perspective is focusing on maladaptive defense mechanisms that are resulting in this behavior. And one defense mechanism, metaphorically, I think is played out in this particular situational episode, and that is reaction formation, right? Turning it inside out, having an impulse and discharging it in its 180-degree opposite form. Now, what's interesting here is that the individual who's struggling with obsessive compulsive disorder usually does not employ reaction formation. What they employ is another defense mechanism referred to as undoing. So it's an act that would symbolically undo their conflict or their prior experience. So that's the ritual that undoes, therefore alleviates the anxiety. Those rituals, of course, could be counting, washing hands, etc. Hence, the individual presents with perhaps clinically significant compulsive behaviors. Those behaviors are a result of a defense mechanism called undoing. Those behaviors then become, that is, those compulsions become defining of obsessive compulsive disorder. Now, there's a significant comorbidity between this condition, this anxiety disorder, and a personality disorder called obsessive compulsive personality. But in obsessive compulsive personality, a condition that Jerry Seinfeld does have, the perfectionist, the individual who requires order and control, that is Jerry Seinfeld. They employ a different defense mechanism, and that defense mechanism is reaction formation. People have an inner chaos that through reaction formation gets turned around to its complete opposite and discharged. So the chaos that they're feeling inside is manifest, is phenotypically expressed by total order and control, its 180-degree opposite. And so interestingly, we do understand that Jerry Seinfeld is afflicted with obsessive compulsive personality, and the defense mechanism that likely underrides or influences that is metaphorically demonstrated by his turning his jacket inside out.
Is it perhaps because he was having those intrusive thoughts and going through that at that time, and in this, particularly in this episode, that he is able to kind of goad George about his sort of compulsion to sing the Les Mis song?
Yeah, I think, these two characters have a very unique relationship. And a lot of times, what Jerry is thinking not only influences Jerry's behavior, but also influences George's as well. They're quite enmeshed. And I think their relationship certainly does support your observation, because George does himself become obsessed. And therefore, to the extent that it's clinically significant, may also demonstrate aspects of obsessive compulsive disorder with regard to the song that he can't get out of his head. And so now, when Jerry then informs him that the German composer Schumann had the same difficulty and quote unquote went crazy, what then happens to George?
He like tries to stop himself from trying to continue singing, but then he kind of struggles to do that throughout the episode. He keeps singing it again, time to time.
And he definitely struggles. And when he struggles, how does he cope with his struggles?
He kind of like tries to like stop himself. He like kind of, I guess he's like kind of like, I'll stop it, like to himself, but and then he kind of gets upset. That's how he seems like in the episode.
He definitely gets upset, and he actually becomes somewhat preoccupied with perhaps having an outcome similar to the German composer, right? And to the extent that we see this, and again, we're cheating a little bit, or at least I am, because this happens in other episodes pertaining to George Costanza. He begins to demonstrate traits of a condition referred to as illness anxiety disorder. He becomes preoccupied with having or acquiring a severe illness. And that is the condition formerly known as hypochondriasis, presently classified as illness anxiety disorder in the DSM-5. And George definitely is afflicted with this. And this particular episode supports that as a provisional diagnosis of George Costanza. And we have other episodes, albeit not assigned to discuss today, that support this diagnosis. Illness anxiety disorder, formerly known as hypochondriasis. One quick test-taking tip is that in hypochondriasis, that is the way this particular condition was formally described, the individual was preoccupied with having a serious illness, right? And again, here it would be this condition of quote unquote going crazy. The revision in 2013 was that the individual was preoccupied with having or acquiring a severe illness. So there's a little bit of a tweak in the definition, a change in the name to illness anxiety disorder. We have about 5 minutes left. Any observations on Kramer?
I guess regarding how, like in the beginning, when he keeps asking for the first jacket, and then later when the suede jacket gets ruined, he asks for that too. I thought that was kind of something that they were trying to point out in the show.
Yeah, I think with regard to that behavior, it might be wrapped up in a larger condition, perhaps rule out hoarding disorder, right? So, we're talking about obsessive compulsive disorder, and hoarding was actually a diagnostic criterion of OCD. However, probably largely due to some television shows, it became a very popular diagnosis at or around 2010. And as a result, the American Psychiatric Association in 2013, with the latest revision of the DSM, pulled hoarding out of the definition of OCD and created its own illness called hoarding disorder. So hoarding disorder now exists. and it exists in the chapter of the obsessive compulsive and related disorders, which again shouldn't surprise anyone. I really don't know if Kramer has it, but certainly his behavior prompts a discussion and a brief review of hoarding disorder. So, with regard to this particular episode, just some closing comments. We see some of the DSM here where we're focusing on abnormal thoughts, right? Obsessions, preoccupations. What an obsession is versus a preoccupation is somewhat arbitrary, but I think we could both agree, or all agree, that it's an abnormal or deficit in thought, specifically thought content, right? So, the mental status exam is broken down to several components, one of which is thought. Thought itself is categorized as thought content and thought process. Thought process is nothing more than speech. So cross it off your list in terms of your 8.5 by 11 sheet of paper that you use as a cheat sheet to provide the MSE, and discuss your findings under speech, another domain of the mental status exam. And that just leaves thought content there as far as the breakdown of thought. Just think about thought content. Now, thought content, of course, it starts with suicidal thoughts, homicidal thoughts, but it also includes themes such as preoccupations and obsessions. So that's where, in terms of just figuring this out and categorizing this in your head, these deficits belong specifically obsessions and preoccupations. Any abnormal findings would be reported under thought/thought content. That said, individuals with these deficits certainly may have any or a few of the conditions we discussed today. A preoccupation with having or acquiring a serious illness would be illness anxiety disorder. These intrusive thoughts themselves that impair functioning would be OCD. When the thoughts are about difficulty discarding possessions that have no sentimental value, then we call it hoarding disorder. So 3 conditions: hoarding, OCD in the chapter of the obsessive compulsive and related disorders. And I think illness anxiety disorder, while currently in a different chapter, at some point soon will also be moved into that chapter to be shared with OCD and illness anxiety disorder. About a minute left. Any final thoughts? All right, that concludes our discussion this morning on the jacket, red team. I'll see you in about 30 to 40 minutes, and then we'll see everybody back for our 12:30 discussion over Instagram Live. Thank you.
Thank you.